Now, this afternoon, we have been blessed with the privilege of having presentations from two professional general practitioners, namely Dr. John St. John and Dr. Stephen Lawrence, which is no stranger to those of you who has been attending or have the events in the past. They have given us yeoman service over the years. And both of those speakers will be speaking on the topic of coronavirus or the COVID-19. Now, Dr. St. John will be our first speaker, followed by Dr. Lawrence, and there will be a question and answer session following each individual presentation. Now, during the presentation period, participants will be muted and is encouraged to register your questions via the chat room. For those of you who are unable to register your questions, I suggest you indicate your intention by raising your hand, and we will hopefully allow you to ask your questions. Thank you very much. Now, since the occurrence of the coronavirus pandemic, there has been many conspiracies and theories and misinformation propagated through various social media outlets. We've found lots of people that self-profess experts. And all this information has served to confuse and distort current truths about this dreadful disease. So this afternoon, we are hopeful that some of your concerns and suspicions will be addressed and serve to empower you to make informed and fact-based, and I say fact-based choices from reliable sources. To this end, I'm going to introduce our first speaker, Dr. John St. John, who will be speaking on the topic of building back better, building back better. Dr. John St. John.
Thank you very much, and good afternoon, everybody. It's always a pleasure to be part of this Health Day for the Willesden New Testament Church of God. So thank you very much to Mr. and Mrs. Eastman and the health team for inviting me to speak at this event. And I'm sorry we weren't able to meet last year because of COVID and the pandemic, but we're back again with the benefit of the new technologies. So I'm going to be talking about building back better. If I can just give you a little bit of background before I go into the talk. So I work as part of the Northwest London Diabetes Transformation Programme. So that is 8 boroughs in Northwest London, including Brent. I work in West London and I work in Brent as part of that transformation programme. And I also do a voluntary role as a Diabetes UK clinical champion. So that's people who are working in diabetes who want to improve the quality of care for those people living with type 2 diabetes and type 1 diabetes. Now, in addition to that, being a local healthcare practitioner, it's been very important to me to do whatever I can to make sure people have information about, first of all, COVID-19, and then also about the vaccines. So I've been doing quite a lot of work with Brent Council, the local hospitals, so Norfolk Park, Central Middlesex and Ealing Hospital, and in the communities of West London, Brent and other local areas, giving people the information about COVID-19 and also the vaccine so that people can make what I would call an informed choice. So you would have the information at your disposal and you can decide what's going to be best for you, what's going to be best for your family, and what's going to be best for our communities. So I just wanted to give a bit of background because today I'm not going to be talking about COVID-19 or the vaccine specifically. I'm talking about what happens now. And Dr. Lawrence will be talking about COVID-19 and the vaccine more specifically. So let's look to the future. Okay, I thought this was going to happen, so bear with me a second. I'm going to have to stop sharing my slides for a minute and restart, and so bear with me. Okay, there we go. So as you may know, COVID-19 disproportionately affected Brent. It arrived early in Brent. It was heavily hit as a borough, and that impact, even within Brent, was not felt equally. So the areas of Church End and Alperton, which you would obviously know if you live in Brent, saw the highest numbers of cases and, unfortunately, the highest numbers of deaths. So in September 2020, there were 493 deaths in Brent, sadly. May of this year, we had 849 deaths, sadly, in Brent, with a rate of 258 people per 100,000 of a population. And that's higher than it is in England, because in England, the rate is about 230 people in 100,000 population. So you can see that Brent was severely affected. It was affected early on, and it was really heavily hit. One of the things I want to also say is that we learnt more about the virus as the time went on. It was a new virus, so it took a bit of time to get to know it, and I don't think we know everything about it yet. We're learning more and more about it. But over the next few slides, what I want to show you is some of the things that became very apparent from the beginning. So the presentation of this slide would not be familiar to a lot of people, but if I can just explain what we're looking at here. So if you can see, there is a red line down the center here where my arrow is moving, okay? And that means that you have an equal chance of having something happen to you. If you're on the left-hand side of that red line, it means you have a decreased chance of something happening to you. And if you're on the right-hand side of that red line, it means you have an increased chance of something happening to you. So I just wanted to explain the layout of what these diagrams are about, because people may not be familiar. At the beginning of this pandemic, it became apparent very early on. If you look to the top left-hand corner, we're talking about age groups. And as you increased in age, you will see that your chances of dying with COVID-19 increased. So that when you were in the 70 and 80-year-old age group, your chances, unfortunately, of dying with COVID-19 were about 12 times that compared to somebody who was below the age of 50. On the next section of this diagram, you'll see in terms of how gender affected your risk. And gender affected your risk if you were a man. So males were more at risk of dying from COVID-19 compared to women. The next aspect is obesity. And again, you will see that the risk of dying from COVID-19 if you were obese was increased by 1.5 or over double the risk compared to somebody who wasn't obese. I'm using the same format for the diagram to show you the risk of ethnicity. So you will see that 1 was classed as somebody who was white. So if you were white, you had an equal chance of dying or not dying, let's put it that way, from COVID-19, compared to if you are of mixed heritage, South Asian, Black, or other ethnicity. You can see each one of those ethnicities is on the right-hand side of that red line, meaning you are increased risk of dying from COVID-19. The next aspect is in terms of what we call your socioeconomic status, so your financial status. Underneath that is diabetes, and you can see all of these things are on the right side. So that's the right side of that red line, making you at increased risk. diabetes, cancer, malignancy, kidney problems, asthma, chronic lung problems, heart problems. Hypertension at the beginning of the pandemic didn't seem to be associated with an increased risk, as you can see that's on the left-hand side, but chronic liver disease, stroke or dementia, other neurological diseases, transplantation of organs, or if your spleen wasn't working properly, all of those things increased your risk. So that was the information that we based our knowledge base on at the time when we didn't have a lot of knowledge, but it was early on in the pandemic, but it gave us pointers as to people who were at increased chance of having, unfortunately, death from COVID-19, and therefore enabled us to identify groups that were at risk and to help those groups perhaps do something about it. So if I pull all that together, and if we look at Brent, for Brent, it was the community is more likely to die if they got COVID-19 infection. Black people were above a 3 times increased risk. People from Bangladesh and Pakistan, 2.5 times increased risk. And people from India, around double the risk compared to somebody who's white living in Brent. Men were more likely to die from COVID-19, and certainly age was definitely associated with an increased risk. So the older you were, the more likely, unfortunately, if you caught this infection, you were to die from it. And people with health issues, diabetes, heart disease, obesity, respiratory issues, they were more at risk, as were frontline healthcare workers, social care workers, taxi drivers, bus drivers, people who were at increased risk because they're coming into increased exposure with people from through their work. Okay, so what have we learned? Age is a massive factor in increasing your risk. Gender, obesity, ethnicity, and your socioeconomic status, and certain medical conditions as well. Well, if we look at that, we can't do anything about our age. I mean, some of us may try, but we can't. We can't do, for some people, for most people, gender is not something that you can change. Ethnicity is not something you can change. Socioeconomic status, if you do the lottery, okay, you might change that. Medical conditions are there. But certainly the big one for me was obesity. And we can certainly do something about that. And that's one of the things that I want to concentrate on in the talk today. Could we just make sure everybody's muted, please? Thanks. So in the medical conditions, diabetes was top of the list. And diabetes is very much tied in with obesity. So I think that's what I'm going to concentrate on as an example of what we've learnt and perhaps what we can do better. Okay, so I'm using diabetes as an illustration of a medical condition where we've learnt something and perhaps going forwards we can do something better, and it's very much tied in with obesity. So that's what I'm going to use as an example. Okay, bear with me. I think I'm going to have to stop sharing again. Whilst I do that, are there any questions so far? If you want to raise your hand, because we're not a huge group, so perhaps if you raise your hand. Okay. So using diabetes as an example, type 2 diabetes, the risk of diabetes, the chances of getting type 2 diabetes are increased by age, ethnicity, other medical conditions, family history, being overweight, having a large waist circumference, or as a woman, if you've had diabetes during pregnancy. You can see there's quite a lot of tie-in there with, unfortunately, the risks of having severe effects from COVID-19 as well. Age, ethnicity, other medical conditions, being overweight. You know, there's a lot of crossover between the two things. And we know that as Black people, we have a higher risk of developing type 2 diabetes. So this is about building back better. So we're in a better position if, unfortunately, another crisis affects us in the future. So what can we do? Well, I think one of the things that we could do is know more about our condition, know more about our risks, and know how to do better. Maya Angelou says, do what you can until you know better, and then when you know better, do better. So let's use that, okay? So in terms of blood glucose levels, if you want to know whether you're at risk of developing type 2 diabetes and you go and have a blood test, do you know what those figures mean? And a lot of people don't know what those figures mean. The figures are looking at something called your HbA1c, which is the amount of glucose that is stuck to your blood cells, your red blood cells, for the previous 3 months. So many people are familiar with a glucose meter where you prick your finger, check your blood glucose, and it gives you a snapshot of what your blood glucose is here and now. I tried to describe that as more like the photograph of what your blood glucose is doing. And the HbA1c is more like the video. So it's a video of the past 3 months and gives us an impression of what your blood glucose has been doing over the previous 3 months. So if you go and have a blood test done and you have an HbA1c, which is likely the blood test you'll have done if you're looking at your blood glucose, normal is below 42. If you're at risk of developing diabetes, now some people call this pre-diabetes or non-diabetic hypoglycemia, that's between 42 and 47. And if you have diabetes, it's going to be above 48 millimoles per mole. So get to know what your figures are, okay? That's one of the things I think we can do. We can start to increase our knowledge about our health so that we can ensure that our health is as good as it possibly can be. Because as they say, knowledge is power. You can also go on and do something even more proactive than that. You can go on and calculate your risk as an individual for developing type 2 diabetes. I've given you a link here, which you can use. And what I've done is I've given you a link, which is on our local Northwest London website. The reason I've done that is there's lots of really useful information on this website, many different things. So not only about getting to know your risk, but also about healthy eating, also about things like keeping yourself healthy in terms of mind, keeping yourself healthy in terms of physical health, activity, healthy eating, those sorts of things. The other thing is, if English isn't your first language, and for some of us that might be the case, you can use that orange bar at the top, which is called Browse Aloud. So you can change the language of the pages by using that. And if you are having difficulty reading the language, you can get it to speak the page to you. So it will speak the details of the page. But you can use that page to go on and find out your risk of developing type 2 diabetes. It will ask you a few questions. So it'd be things like, you know, have you got high blood pressure? Have you got a family history of type 2 diabetes? What's your weight? What's your ethnicity? And then it will give you a calculation of your risk of developing type 2 diabetes over the next few years. whether it's low, medium or high, and it will also give you some actions you can do. So it might be keeping yourself healthy in some ways. It might be going to see your healthcare practitioner, so your GP likely, to get a blood test done. It gives you actions that you can take, and it gives you a letter with that information, so you can take that along to your healthcare practitioner as well. So here's another thing that you can do, because I want to be quite practical in the talk today about, as I say, helping us to build back better. So that's for us as individuals and families, as well as us as a community. So here's something else you can do, very practical. Take a tape measure, measure your waist. And measuring your waist gives a really good indication of, and it's a simple way of doing it, of your risk of developing type 2 diabetes and what we call cardiovascular disease. So that's disease affecting your cardiovascular system, which is essentially your circulation, so your blood vessels. So that will be organs like your heart, your brain, the legs, those sorts of things, okay? So it's a very simple thing that everybody can do, and that gives you an indication of your risk of developing these conditions. And it tells you whether you're increased risk or at greatly increased risk. And I'm sure you might remember my tape measure where it's got the red, amber and the green. So when you measure your waist, you can easily see if you're okay, at risk, or very much at risk. And gentlemen, just to say, it's the waist circumference, not your trouser waist measurement, and not beneath any paunch that you might have. And that applies to us women as well. It's got to be around the waist to measure that and see what the risk is. So that's something, again, you can practically do. So I hope I've given you some indicators of things that you can practically do to know your risk, know your current health. As I said to you, that No Diabetes website has lots of information on it. It has information specifically for Black, Asian and minority ethnic communities. So it has things like meal plans, it has a healthy eating section, and you can register on there. Eventually, as a resident of one of the 8 boroughs that make up this Northwest London area, you will be able to see your figures. So ultimately, when it's fully operational, you'll be able to see your latest blood pressure, you'll be able to see your latest blood glucose, your latest urine test if you've had that for, let's say you've got diabetes or at risk of developing type 2 diabetes. All of those figures will be put on there for you as an individual if you register on this website. It's not fully operational yet, but you can still get all of this other information. It's the personal information that's not fully operational on it yet. So I'm saying know your risk, know your figures, and then the No Diabetes is the website. Okay, so some practical help using diabetes as an illustration of what we call a chronic or long-term health condition, which has been really, people living with that have been really adversely impacted by COVID-19. And I think moving forwards, we have to look after ourselves perhaps better so that we don't have these terrible impacts from the COVID-19 virus or any other crises that might arise in the future. Okay, so moving away from diabetes, thinking about things like obesity, which portion of rice would you normally eat? So I've used jollof rice here, but this could be rice and peas, this could be basmati rice, any type of rice. There's more of us on now. I was going to say, put it in the chat. It's difficult, I can't see the chat, so I won't be able to see that. But for you yourself at home, think about it. When you're having your meal, what portion of rice would you have? Why have I put that there? Because if you're thinking about obesity, if you're thinking about being overweight, if you're thinking about your waist, then perhaps if you're having portion size B, you might want to be trying to have more like portion size A, and the same things applies for portion size C, because if you're eating more food, the chances are that will translate to increasing your weight, and that can then lead to you being overweight, or what we classify as being obese. I didn't put in one of the slides I've got about body mass index today, because I think body mass index is a way of telling us as healthcare practitioners if somebody is overweight, but it's one way. And in some ways, the waist circumference can be more sensitive to people who are actually carrying excess weight in an area that's more likely to cause things like type 2 diabetes or cardiovascular disease. So I haven't given body mass index information today, but it is something you can easily work out if you'd like to do that. So healthier eating is what I'm saying is another way for us to build back better, because that decreases your risk of being overweight, decreases your risk of being obese, decreases your risk of developing those long-term conditions which were so adversely impacted by COVID-19. So how could you do that? In very simple terms, because what I want to do is give you sort of practical things that you could try from today. You may not try all of them. It'd be great if you did, but maybe try one or two. So aim for less than a teaspoonful of salt a day, because actually the recommended amount of salt that you should be having a day is a teaspoon. And so whether that's with seasoning, or whether that's if you add salt to food when you put it on the table or on the tray, try to keep it less than a teaspoon of salt a day. Maybe you might try to reduce your portion sizes. So I gave the example of rice just now. Maybe cutting down a little bit on that. Whether it's yam, whether it's plantain, whether it's green banana, whatever it is you're having, maybe just try and cut down on that. Or maybe if it's takeaways, maybe try and have those less. And also another tip that you can try is measuring the oil. So instead of just pouring the oil from the bottle, maybe use a tablespoon, and you'll find even that will help you to use less oil when you're cooking. And that applies to whether or not it's olive oil, or whether or not it's sunflower oil or vegetable oil. You know, those are healthy oils, but still, if you use a lot of them, it can become unhealthy in the way you're using it, not the oil itself. Okay, so a whole list of things here. I only went from A to B of things you can do to be more active, because there are so many benefits from being more active. I'm not going to call it exercise. I think it's about, well, I put move more and sit less. And this can translate to don't sit in front of the television from 7 o'clock till what o'clock, watching every soap that's on, never moving from the chair, only moving to press the remote to switch from one soap to another. Try even to get up during the soaps. Try even to get up and go and do something else. Try turning off the television, and I'll say a bit more about that later. But it's about moving more. So whatever you're doing now, can you move a little bit more? Is it stairs that you could walk up instead of taking the lift? Is it, if you're on the public transport, could you get off a bus stop earlier? Somehow can you sit less? And, you know, as healthcare practitioners, we can be guilty of this as well, because, you know, a lot of our working day can be spent sat down, talking to people and not moving. So one of the things I use is my phone. It has a pedometer there where I can monitor how many steps I'm doing. And I try and make sure I get out and I do a walk every day. So since the pandemic, that's one of the things that I've been doing, not only for my physical health, but also for mental well-being, because actually being more active can help you, your mental health as well. And maybe try one new activity. So from A to B here, when I looked on the Brent website, you can do aerobics at Bridge Park. Not sure if it's open at the moment, but hopefully we will be, everywhere will be fully operational in the near future. But remember, if not, you can always get out and walk the way I do, or do something at home. You could do badminton, you could could do aquafit when that's open and available again. But there are still lots of things that you can do, even if you can't go and do those in one of the local sports centres. And Brent has a lot of active spaces in the parks and outdoor gyms, so there's always things that you can do. Okay, so what about your mental health and mental well-being? You know, it's been a very difficult time, I think, for absolutely I don't think anybody can say that they have not been touched and affected in terms of their mental well-being from this pandemic. Unfortunately, I, like lots of people, have lost lots of people, lots of members of my family, and unfortunately very, very close friends as well. And also had people who have suffered disability as a consequence of COVID-19 infection. And all of that affects your mental health. You can't grieve the way you normally could. You can't have a funeral the way you normally could. You can't come together the way you normally could. How do we look after ourselves? So again, I want to give you some practical and easy tips that you can do. I've given a website here, which is an NHS website, where you can do a self-assessment yourself to see how your mental well-being is at the moment. So you can do that in the comfort of your own home, in the privacy of your own home, because I know there's a lot of stigma around mental health. There shouldn't be, but there is. So if you feel you want to do that and just gauge where you are, then that self-assessment quiz is there for you. But if you know for yourself that you're not feeling as good in your mood as you normally would do, there's different things you can do. I've said be active, and I know for one of the things that helped me through, is helping me, I should say, through the pandemic, is going out and walking. So I go outside, so I'm outside, I can hear birds, I can see some trees, I can see some green, I can see some people, actually, because if you go to walk at a certain time, you tend to see the same people. You can make some interaction, you're in touch with nature, you know, you're exercising, and those well-being hormones are released in your body. So being active in some way is really helpful. And I was saying about sitting down for hours and not moving. Switching off the television sometimes and just talking can be really helpful as well, because we can lose ourselves in the television and not deal with the emotions that we might be feeling. And I think a good tip that I saw was not to make all your social connections on social media, because although it's called social media, sometimes it can be quite antisocial. So try making those connections, be it on Zoom, just having a chat with somebody, whether it's like me, sometimes, going out for a certain time for a walk, I tend to see certain people and you have a little chat. Whatever it is that's working for you, do try and make sure you keep those social connections, because they're really important for your mental well-being as well. So as a church, I think there is something also about helping us to build back better. So Professor Fenton, I should say, Professor Kevin Fenton's excellent work about looking at how COVID-19 impact Black, Asian and ethnic minority groups gave us some pointers about what we could do for the future. One of the big things that came through was about community engagement. So however that community engagement arises, it's really important. So church is a community, it's a very strong community, and churches can be that social interaction, can fulfill that activity role. So, perhaps as a church, you do an activity challenge. You have groups of 2 or 3, and you have to do a certain amount of steps as a group per week. And you challenge each other, and doing it together is always more fun than doing it by yourself. And if I can help in any way, please let me know. Professor Fenton also said we need more data. We need more data about how things impact us as ethnic minority people. And we also need champions. So we need our voice out there so that we don't feel things are done to us, but we are part of the process. Part of that process for the local hospitals, Norfolk Park, Ealing and Central Middlesex, meant that those of us who were concerned about this impact of COVID-19 on our communities, our local communities, got together and we did some drop-in Q&As for the staff at the hospitals. And we did some videos, which I've given a link in the resources, to try and give people the information that they required to make an informed choice about whether or not they should take the vaccine. So that was about community engagement. That was about looking at the data, because within the hospitals, there was the data available and we were the champions. It was just an example. We haven't done the step challenge yet, but you never know, we might do that as well. So in conclusion, I've used the same quote. Beloved, I pray that you may prosper in all things and be in health just as your soul prospers, because health is about so much of us. It's about our faith, it's about our physical health, it's about our mental well-being, it's about our social interactions, all of those things. So we want to be completely healthy. And I use, when I've been doing webinars recently, two things. One is Ubuntu, which is a Zulu word, which means I am because you are. And I'm really keen that I can't be healthy until all of us are healthy, until all of us have the information that we require to be healthier and to prosper. So I want all of us to be healthy, because if we're all healthy, and that's locally and that's globally, yes, I think because we have a responsibility globally as well, then we will all be healthy together. And the other thing I normally say is each one teach one. If there's one of the tips, whether it's getting the tape measure, whether it's turning off the television and talking, whether it's going for a walk every day, that you've learnt today that might be useful for you, each one teach one. Go and tell somebody else so that they'll have that information as well. So I want us to start to be healthier as individuals, as families, and as communities, as a community. And that may involve eating healthier, and I've given some tips about that. That may involve being more active. I've given some tips about that. Taking care of your health, so knowing those numbers and knowing your risks, and having more knowledge, because as I said at the beginning, knowledge is power. So I want all of us to be healthy. So thank you very much for your kind attention. I hope that the technology held up for the talk. And I think there may be some questions in the chat, but if not, hopefully you've got some questions for me, because unfortunately I won't be able to stay for the whole meeting today. But I really do wish you all well. Thank you very much.
Yes, Dr. St. John, we've got a few questions for you. One of those questions is, why is ethnicity a determinant for likelihood of dying? Why is ethnicity a determinant for the likelihood of dying?
So it wasn't a likelihood of dying, it was an association, unfortunately, of people losing their lives. So it was sort of looking at the situation and trying to learn from that situation. So it was found that people of a Black, Asian, or other ethnic minority group were associated with an increased risk of dying. Now, for causation, to say that one thing leads to definitely another, we would have to do a trial. That wasn't a trial, it was looking at the evidence and seeing what that showed to give us signals as to things that we might need to look out for. So there's a hypothesis that ethnicity was linked with things like socioeconomic factors, but you can't say all people from ethnic minorities are having difficulty in terms of financial factors. Because I want to also say that in terms of healthcare practitioners, the vast majority of the people who sadly lost their lives at the beginning of COVID were from ethnic minorities. Now, they're not having the same financial pressures as healthcare practitioners as somebody else might do who is doing another job. So it couldn't all be about socioeconomic factors. Was it associated with things like obesity? Well, not all people from ethnic minorities are obese. It was very difficult to understand if there was one thing that was increasing the risk or if it was multiple factors of people from ethnic minorities that was increasing the risk. Some ethnic minority people are living in houses of multi-generations. So was it that because there was increased exposure within the house that was increasing the risk? So we had details of associations, we don't have details of causation. So I hope that helps to answer that question.
Okay, yeah, that moves. Yes, that moves on. That ties nicely into the question because it follows: are the risks related to those on the poverty line?
Yeah. So from those first charts that I showed, again, association was definitely with people of socioeconomic financial challenges. Let's put it that way. Yeah. So if you were having more financial challenge, yeah, if you, I hate to use, it's the words we use are deprivation, okay? If you had more socioeconomic deprivation, your association of dying from COVID-19 was increased.
Okay.
Okay.
Next question is, what weight do you classify as obese? And I'm assuming that they're meaning in numerical terms.
Yeah, so I have a nice slide which shows it's actually a woman of the same height, but a different weight. So it's not a specific weight because that's why it's for you as an individual, you have to go and work that out. And there's lots of websites. If you put it into one of your search engines, do body mass index, it will come up. You can do height and weight, and you can do height in inches, you can do height in centimeters, weight in stones, weight in kilograms. But it's your weight compared to your height. So it's not a specific weight as such, it's what your weight is compared to your height.
Okay. Okay. The next question is it better to use air fat fryers as a healthy option than frying?
Okay, so somebody's going to have to educate me about the air fat fryers because I haven't got one. But I think, as far as I know, you put like some spoons of oil into it and then it fries it. Is that right?
Yes, it's not even a spoon, it's very little oil that you...
Right. So chances are yes. I think we're answering the question there because remember, if you're going to fry something, what do? You normally take the bottle of oil and you pour it and you fry it. Yeah, whether you're deep fat frying or whether you're frying something, not deep fat. So you pour it and you fry it in that, compared to using spoons of oil in an air fryer. Is it air fryer?
Right, air fryers, yes.
Yeah. So chances are, yes, it's going to be healthier for you because it's going to be less fat that you're using.
Right.
The next question, I'm not sure if it's a question or statement, but it says, it's been recently reported that young adults' mental health has been affected by the pandemic. Example, suicide, anorexia, and increased anxiety, etc. I think that's I don't know if it's a suggestion or question.
Mm-hmm. Well, I think it's like a tragedy on a tragedy, isn't it? Mm-hmm. Because the pandemic has been really difficult for so many people, and particularly the young people. I can't say particularly the young people because it's been a tragedy for so many people in different ways, because elderly people have been in lockdown, and I've seen deterioration in lots of my elderly relatives because they haven't been able to get out and about the way they normally would do. For young people, they've been affected differently, as severely, but in a different way. And yes, their mental health has really suffered. And I think it's a tragedy on top of a tragedy. So yes, I absolutely agree. And how do we build back better? Well, I think I've said about knowledge, and I think awareness and lack of stigma. I think it'd be fantastic if we could lose the stigma of mental health, because there's a huge stigma around mental health. And I think it'd be good if we could lose that, because by doing that, we can become more aware of it. And it's less of an issue then if somebody experiences that. So for young people, it then would be a lot easier for them to go and seek help, rather than unfortunately ending up in these situations of eating disorders, unfortunately things like suicide, just or poor mental health. So losing the stigma would be brilliant. And if we're talking about building back better, perhaps that's something that we can look towards the future of doing. Again, you know, a challenge, not institutions, but groups, let's put it this way, I challenge groups. If we're going to build back better as a church with a fantastic health team, perhaps there are things that maybe you could do about mental health. Maybe one of the health days could be about mental health, and that may be one of the ways that some of us can lose that stigma that we feel about mental health.
That's a wonderful suggestion, which we will take on board as a health team going forward.
Okay.
Next, someone have mentioned, thank you for this informative presentation. Is it possible to get the slides?
Sure, absolutely fine. And the last slide has lots of resources on it. So it's one of the slides that I use when I've done talks about COVID-19 and the vaccines. So there's lots of information there about people who might be concerned about, you know, is vitamin D the answer to treating COVID-19 infection, or hot baths, or, you know, it's one of the what they call myth busters. So if you are getting social media information about some of these things, you might want to go and check it. And it also, there's a site which does a fact checking. So it's got that as well. And it's got those videos that we did in the local hospitals.
Okay. Thank you. Another comment in the chat room. It was easier to motivate yourself to do the right thing, for example, like walking, etc., during the first lockdown. Have any tips?
It's always easier if you do it with somebody else. So buddy with somebody else. Find somebody as a friend, find somebody in your family, find, I don't know, maybe grandchildren, you know, maybe somebody from church. You get together with that person. Let's see who can do more steps. Yep. You know, or you're going to meet together in X park, and that's going to be on a, you know, Saturday morning, and we're going to walk for an hour. You can do socially distanced walking outside, and outside is always much more safer than inside. Maybe you can do that. It is difficult, but it's always easier if you do it with somebody else. You know, we're social animals, aren't we? You know, we'd like to be amongst and with people. And so, yeah, let's try and do something together, because we'll be helping each other. The funny thing is, you think you're helping somebody else, and you're actually helping yourself as well at the same time.
And someone has written that they love that quote from the Maya Angelou that you made.
Yeah, I love it as well, because, you know, we try our best in life, don't we? And that's all you can do. But when you know better, and arm yourself with knowledge, yep, so you do know better. But when you know better, the expectation is to do better. Yeah.
Thank you. And the individual that had asked for whether you had the information on the slides, she had left her email contact details, which I would forward to you.
Okay. I think you've got the slides, so you could just feel free to email that person. Yeah. Yeah, that's I'm fine with that.
Thank you. Any more further questions? No.
I can see somebody. Yes, somebody's got their hand up.
No.
You'll need to unmute him, I think.
Bear with me.
Yeah.
Okay.
Brother Eric?
Yes, doctor, I'm glad for the information regarding the blood test, because about 2:30 I need to do a blood test, and it's good to refresh yourself the correct number.
Yeah, absolutely.
Yes,
And did you make a note of them?
I make a note of them. Yes,
Fantastic. So your results will probably come through next week, won't they? So
yes,
then you can have a look and see where you're at. And I think
yes,
it's about knowing where you're at. So then you can see, okay, is everything fine? Do I need to do something about this? Or, do I need to go and talk to my doctor about it, or practice nurse? So yeah, it's fantastic. I'm really pleased.
yes. Thank you so much.
Yeah, I mean, because the thing is, we have an MOT for our car, and we get our boilers checked every year, but we don't always do that for ourselves. And I'm so
Yes,
glad that you're doing that, Brother Eric.
yes. Thank you so much. Thanks.
Okay.
Any other questions? I take that as a no.
Was
So-
that I heard somebody, I don't know, maybe not.
Faintly in the background.
Oh, okay, all right.
I don't know if it's someone who wants to ask a question or.
No, well, I don't
Okay.
think there's any further questions towards you, Dr. St. John. At this time, I'd like to thank you for that marvelous and very informative presentation, as always.
Thank you.
And we hope to see you again next year. Yes.
Yeah, and maybe face to face then. Let's see.
Yeah, I know you're on time constraint today, but
Yeah.
enjoy the rest of your day and stay safe.
Thank you very much. And as I say, wishing everybody good health. And you're obviously in fantastic hands now, because Dr. Lawrence is going to be speaking. So
Thank you.
take care. Bye-bye.
Bye-bye. Bye-bye.
Bye-bye.
Thank you so much, Joan.
I'm sure that you have been blessed and well fed with the presentation of Dr. St. John. And the next speaker that I will introduce to you is no stranger, as I said before, Dr. Stephen Lawrence. And the same process will apply. He will do his presentation, followed by question and answers. So at this moment, I'd like to present Dr. Steve Lawrence to you.
Right, so just make sure that I'm, so can I just check that you can actually hear me? I'm coming through.
We can hear you loud and clear.
Loud and clear.
Great, okay. Well, thank you so much. And also Joan St. John, we've been colleagues for a number of years, and it's really great to see Joan St. John, who I have to sometimes make sure that I'm addressing the right Joan, because Joan is also the name of my sister. So, but no, great to see you. And it's a fantastic privilege to be here today, to come along and to speak again at the Health Day. Now, this has been actually entitled Coronavirus Part 2, and I suppose it then builds on the experience that we've had from the previous presentation. But how much things have changed in a relatively short period of time. They say that a week is a long time in politics, but in just a few months, we have gained a lot in terms of understanding around this dreadful disease. But sadly, as Dr. St. John has mentioned, we have also, many of us are familiar with not just the stresses of this pandemic, but also significant losses. And for that, I think I would like to obviously express my condolences. My name is Stephen Lawrence. I'm sure many of you know me. I work as a GP principal in Kent. I'm also an associate clinical professor at the University of Warwick Medical School. But my other interest, similar to Joan St. John, is that I have a very strong interest in diabetes. I am part of a committee membership called the Primary Care Diabetes Society, having previously been the lead for the Diabetes UK and the Royal College of General Practitioners for diabetes. I'm actually going to spend a relatively short period of time going through an overview of where we are now with regards to COVID-19, coronavirus, whichever adjective you want to ascribe to this. And then I want to open up the floor for questions, because in my experience, it is the question part of this where hopefully we get the chance to break down any misunderstandings, myth bust, as Joan said earlier. And remember, there's no such thing as a silly question. It's really important that you use this opportunity to ask questions. The advice that I give and guidance that I give, if I don't know the answer, I will tell you, but it should all be evidence-based. Okay, I'm actually going to, this is just feeding back and telling me that it's not quite clear, so I'm just going to quickly put that through. If you just bear 1 second. Sorry, Mike, it's just 1 second. I'm just going to put this back on. It's not recording. I'm wanting to record this so that you actually have a copy of it. So it was telling me it wasn't recording, so I need to make sure that's actually on. So it's just as happened with Joan. It's just making me restart my system. So I won't take too long for that to just restart. I've still got sound because it's going through a different area.
Be reminded that you can use the chat to post your questions to Dr. Lawrence.
Right, okay, I will start this again. One of the cameras has failed, so it doesn't matter, I can manage without that. Okay, can I just check that you can still hear me?
Yes, we can.
Yes, good. Okay. So as I was saying, sorry, I just wanted to make sure this has been properly recorded. So as I was saying, so no such thing as a silly question, and my aim is to cover the aspects of not just the coronavirus, but also aspects relating to general health as well. So first of all, what we do know about, what do we first know about the global situation with regards to coronavirus? Well, the situation of the global situation is that we have a pandemic where every single part of the world has been affected. There's not one part of the world that has been spared from this. And if we just look at a global view and see where we are at least 2 years on from COVID-19, the 19 coming from 2019 when this was first uncovered, though it's arguably the case that it was around before it was actually officially recognized. And here you can see that the global coronavirus or COVID-19 cases is at 162.5 million cases. And the number of deaths as of the beginning of this month was just under 3.5 million people. Now, if we put this into some kind of context, London is the largest, clearly capital, the largest city and largest populous city of the UK, and has around 11 million people. So if you can imagine that just just under a third of people in London, 1 in 3 people dying from this would give you some estimation as to the number of people who have died globally. Or put another way, Birmingham houses approximately 1.1 million people. So you could take 3 of Birmingham, the whole of Birmingham, and that again would approximate to the number of deaths that we've seen from coronavirus. And to put it into another context, we had in World War II, 70 million people, 70 million people died during the whole of that 5-year conflict. And here we've had over several months, over about 20 or so months, almost 3.5 million deaths worldwide. So you can see that this has been a scourge that has not spared any particular part of the world. Yes, we have seen a great recovery rate, and of that 162 million people, you can see that despite the deaths, and many of us have, as I say, are sadly familiar with people who have died, the recovery rate looks good. 140 million of the 162 million people have recovered. But I want you to hold and suspend your thoughts about this, because how do we define recovery? And you may perhaps put this into a different context as we move on through this, this talk. So looking at the total deaths, going back to way back to the beginning of 2020 in January, when it was just being discovered, and you can see how this is looking globally. The numbers of deaths have rapidly risen. So within the first 6 months of the emergence, the recognition that there was this condition called coronavirus, and we've now shortened it to COVID-19, that we had almost 1 million deaths worldwide. And that has continued, it's plateaued off, but it's continued to rise. And hearing the information around the very effective vaccination programs in different parts of the world, you might think, well, why is it rising? And this speaks to some of the inequalities, not only that we see within the UK in terms of COVID-19, but also in different parts of the world in terms of mobilizing their vaccine program. So if we were to take a snapshot at different times, different parts of time. So this is looking at the daily deaths on what we call a 7-day average or a 7-day rolling program. You can see that if you look at any particular day, then it will tend to, the rate will appear to be going up or coming down. But very importantly, as you look at the previous slide, the general trend is that the death rate worldwide is still accelerating, is still going up, because we haven't yet managed to get on top of this scourge. And this introduces, therefore, the opportunity to move from a global situation to looking at where we are in the UK. And from there, I will go on to the aspects of the vaccination program. So where are we in the UK? Now, this graph is broken up into 4 areas, and I'm just going to talk through this because in contrast to what we've seen, where we have this 3.3 million people who have died globally, in the UK, 127,000 people have died out of a population of 70 million. And that you might think that's awful, that's an awful scourge. But if you look here, over here, this graph is referring to what we call the 3-month trend, the 12-week trend. And you can see that at least for the UK, we have seen levels of the death rate actually falling quite considerably. So that the latest daily figure, and this actually relates to, this is very up to date, this relates to only the 12th of May, as you can see at the bottom here, that the daily figure of new deaths amounts in the UK, the whole of the UK, to just 17 new deaths. And you only need to cast your mind back just a few months when we were seeing thousands of new deaths each day. Now we're only seeing 17 new deaths. In terms of the total cases, moving over towards the right, just under 4.5 million total cases of coronavirus. And of these, 2,000, just over 2,000 new cases. But remember, despite the fact that there have been 2,000 new cases, if we look at this trend over a 3-month period, the trend is for the number of total cases of coronavirus to be falling. We've got falling death rates, falling numbers of cases, and a very important index in terms of someone's risk of dying and the severity of their illness from COVID infection is their need for hospitalization. And over here down in the left corner in the green, you can see that the numbers of people in hospital is just over 1,000. And again, if you look at the trend graph here, which is looking at the trend over a 12-week or a 3-month period, that is still coming down. And if we look at how things have happened, we've got 38 fewer people in hospital than yesterday. So these are figures up until the 12th of May, so it relates to figures on the 11th of May. So these up-to-date figures, yes, they can go up and down and vary from day to day, but it does trend towards an improvement, at least for the UK. Now, why are we seeing this improvement? Some might argue, well, that's just the general trend of a viral illness that's working its way through the population, like flu, which will gradually settle down. Now, that would be the case, apart from the fact that the big confounding variable in this, as we call it, is that we started a vaccination program in the UK as early as January of this year. So that to date, we have, of the 70 million approximately population of the UK, 36 million people have received their first dose of vaccine, whether that be the Pfizer-BioNTech or the AstraZeneca. And when you look at the second dose, so if you look at the second dose, the figures aren't on here, but those people who have had both doses is around just over 15 million people, so roughly half of the total vaccinated. And again, if you look at this trend graph, you can see that for those who are getting their first doses, it's gone a little bit up and down. It's gone very well initially, and then it started to fall off, and we might discuss why that's happening. And for the second dose, that's shown a gradual trend upwards. So we have falling total deaths, falling total cases, reduction in numbers of people in hospital, and the factor that's going up here in the bottom right is the number of people who are receiving either their first or their second doses of the vaccine. So let's talk a little bit about this vaccine program then, because this was introduced by the UK government back in January. And this was in a response to the fact that we had to do something. The social distancing, the hygiene measures were having an enormous effect on the economy, on people's mental and their health well-being. General practice itself, we feel that we weren't able to properly offer our services to patients. So everything's really quite challenged. And so the only way out of this was felt to embark on a vaccination program. And in my last talk, I spoke about the issues associated with a vaccine program that has been accelerated through the stages of development without the chance for considered development. Now, in actual fact, as we know, what has happened is that it has gone through these stages of development, but this has taken place with the cooperation of many of the authorities, so that the progress has been accelerated. So a lot of what normally happens in peacetime, let's call it pre-COVID time, a lot of the delays are down to the fact that there's a lot of bureaucracy involved in going from one stage to the other and so on. When there is a scourge that is potentially going to cause industry, private lives, public life to fall apart and society to become disorganized, then it is amazing how different organizations can come together so that this phased development for the vaccine was accelerated. It has to be said, however, that the phase 3, which would normally be more prolonged, was slightly shortened, and so therefore we had a situation where the vaccine was being given to large numbers of the population, perhaps at a slightly earlier stage. And there have been some issues emerging from that I will discuss as we go on. But this is a very brief summary of the vaccination program introduced by the NHS. And there are what we call different groups going on this slide from 1 to 9. We actually are on, I think it's 10 or 11 now. But essentially, we focused initially on residents in care homes or their carers, because this was felt to be the most vulnerable group, the group that if they were unfortunate enough to become infected would have a significantly higher mortality. And then group 2 were the over 80s and frontline health and care staff like myself, Dr. St. John, many of you who yourselves listening to this and watching this who also work for the NHS. In fact, of the working population, approximately just under 1.5 million people work for the NHS. So that was a large part of of group 2. And then you can see how it then goes through the different ages as you progress through from group 3 down to group 5, which is the over 50s. We are now tackling the group, which is the age group of the 30s to 40s. And again, we're going to look at the implications for this group. So the most vulnerable first, protecting the NHS, and then gradually working through, because the risk of harm, of death, of what we call morbidity and mortality is reduced in younger age groups, as Dr. St. John mentioned earlier on. So we clearly know that there are benefits for the COVID vaccination, and the benefits are significant with regards to the reduction in chances of death, the reduction, which is mortality, reduction in morbidity, which is basically illness. But in terms of these potential benefits, they tend to be in different groups. So it depends on whether you have a low exposure risk, if you look at the center here, or a medium exposure risk, which you'll see in the next slide, or what we call a high exposure risk, which I'll show you in the third slide from here. Now, I want you to concentrate initially on the left side of this, the blue. So we're just looking at the potential benefits, and we're looking at these numbers per 100,000 people who have a low exposure risk. And this might be people who are living in rural communities, quite spaced out communities, higher socioeconomic status, predominantly low levels of Black, Asian and minority ethnic group representation. So this first slide is low exposure risk. And you can see that for the 20 to 29 age group, the chances of that person, this is per 100,000 people, being admitted to the intensive care unit following infection is 0.8. So less than 1 per 100,000 person. Let's go all the way through to someone who is between the ages of 60 and 69. In a low exposure risk area, which I've just defined, then you can see that approximately 14 people per 100,000 would be expected to be admitted to the intensive care unit being infected with COVID-19 per 100,000 people. Okay. So you can see the aspect of age where that's important in a low risk. Now, bear this in mind as I gradually go through this. We're going to look at potential harms here now, and just suspend your examination of this side of the slide, but just from the purposes of illustration, just see that the potential for harm is relatively lower in the older age group. If you look at this, the size of this sphere, it gets smaller and smaller for the older age group compared with the younger age group. So you can see that the risk is greater in terms of potential harms from the vaccine, and we'll define that in a second, if you're younger than if you're older. The benefits, however, of the vaccine are much greater in someone who is older than someone who is younger. Let's see how this now pans out if we move to a situation where there is a medium exposure risk. So here we're now in the medium exposure risk, and we're looking at the same age groups. So perhaps more crowded together, more people from Black, Asian and minority ethnic groups, more representation of long-term conditions such as diabetes, heart disease, heart failure. Now let's just see what happens here. You can see for yourself that if we look at the 20 to 29 age group, it's still quite low, but significantly greater than the 0.8 that I showed you before. But as we rotate through to the higher levels of age, we can see that for the 16 to 69 age group, you've gone from 2.2 per 100,000 people running the risk of being admitted to the intensive care unit to 41 per 100,000. So you can see that this starts to ramp up and to become very important. If we move on further now, you can see where this is going. If we look at a situation where there is high exposure risk, and I think this perhaps speaks for itself, you can see that for the 60 to 69 age group, the risk is 127, so call it 128 per 100,000, 127 or 128 per 100,000 people will find themselves in the intensive care unit fighting for their lives, having the highest level of healthcare input because they've been exposed to coronavirus. Compare that with a relatively lower number of, call it 7 per 100,000 in the 20 to 29 age group. And again, you can see that the same kind of risk of harm is there for each group. Now, this is actually looking at the AstraZeneca vaccine, which we're going to be looking at in a second, because that's where the controversy lies in terms of what we call the risk-benefit ratio. So there's definite benefit. There's benefit from your first vaccine, and that reduces the chance of you both passing it on and also becoming infected. But it doesn't remove the need for us to still practice social distancing, still practice the hand hygiene, and all of the other measures that have been advised. So the issue that we have with regards to the potential harms and vaccination concerns relate so far just to the issue of the AstraZeneca vaccine. Now, yes, there are issues with the other vaccine, the Pfizer-BioNTech one, with regards to allergic reactions. But the new concern around the COVID vaccination of the AstraZeneca is that of an extremely rare, but potentially life-threatening condition, which, and I put it in red, involves blood clots and unusual bleeding following vaccination. And this is more likely, if you're going to see it, to occur after the first vaccination rather than the second one. Some people with this condition have suffered life-changing effects in terms of their mobility, their ability to function normally afterwards. And sadly, some have actually died from this. Now, these cases are being carefully reviewed, but the risk factors for this condition are not very clear. What is clear, however, and I'm just going to go back on these slides, is, and I'd like you now to concentrate on the left part of the slide, the pink part, is that these potential harms of blood clots related to the vaccine appear to be related to age. So the younger you are, and you can see that it starts to become significant when you get to the 20 to 29 age group, so under 30s. Younger, sorry, I think we've still got some microphones on, I think, in here. If you could actually mute, there's a microphone that's coming through.
Okay.
I think that's okay now, yes. So if we go to for the younger age group, the risk is significantly higher compared to the older age groups with regards to this. Okay. So to clarify the situation, and this is emerging information that is going on, so far, just over 10 people have developed this unusual clotting thrombotic. Thrombotic is just a medical term for clotting. About 10 people have developed this condition for every 1 million doses of the AZ vaccine given. So it just gives you some indication as to how rare this is. Now, for the individual person who suffers this condition, that's significant. You know, it doesn't really matter if you're the one who suffers the condition, that's important. But the likelihood, it's important to know that this is so very rare that the chances of not being vaccinated, causing significant harm and potentially death are much greater than the risks associated with the AZ vaccine. But it's still a risk. And we've seen that this is more common in younger people, occurring around 96 hours or 4 days to 4 weeks following vaccination. So as a result of that, there has been a new directive issued to doctors that this vaccine is very safe and has a very low incidence of problems for the older age groups. So it's perfectly fine for anyone over the age of 30. However, under the age of 30, it is now what we call contraindicated. It cannot be given to anyone under the age of 30. And what about those between 30 and 40? What we do as doctors is we adopt what's called a pragmatic approach. If someone came to me who was aged between 20 and between 30 and 40 and said, look, Dr. Lawrence, I'm still not happy about having this. I'd rather have the Pfizer-BioNTech vaccine, then we would actually work with that for them. We'd give them that, because risk doesn't suddenly just cut off at one age, but certainly the risk beyond 40 years is going to be much, much lower. The other important point on this, before I move from this, is that it has to be also understood that these kind of thrombotic and clotting problems are not new. We've been dealing with these kind of issues for many, many years. And so these conditions still occur naturally. And I remember seeing people, even as a junior doctor years ago, seeing people coming along with these kind of clotting issues. And so there is an association with the AstraZeneca vaccine, but these also occur naturally within the population with no issue associated of vaccination. And it's also, this kind of clotting problem is also a common, not a rare, but a common complication of infection with COVID-19. So whilst this is common with COVID-19 and it is something that occurs naturally, this increased risk, or this signal for increased risk, has not been seen after COVID-19 vaccines, vaccination using other agents like the Pfizer-BioNTech one. So that's the reason why the NHS is making this alteration around making the Pfizer-BioNTech vaccine available to people who are under the age of 30. So I'm going to move on now to long COVID. Now, if you cast your minds back to my first few slides where I mentioned that we had 3.3 million people globally who have died, sadly, from infection with COVID-19. And I mentioned that of the 162 million people who had been diagnosed, the recovery rate has been in the region of around 142 million. But that does not encapsulate this issue of long COVID infection. Now, what is long COVID? The first thing I should say is that there is no internationally agreed definition. This is so new, this is so emergent that the WHO, the World Health Organization, the National Health Service, the American Health Service, they're all trying to grapple with what this is and how do we define it. So each jurisdiction seems to have come up with their own definition. But what is common is that this condition, long COVID, and the symptoms that encompass this start between 3 weeks and 12 weeks after infection with acute COVID-19. The NHS defines it as COVID symptoms or symptoms following on from acute COVID infection lasting more than 12 weeks. That's how the NHS defines it. If you go online and you look at the World Health Organization, they'll have a slightly different definition based on the time. They may say that it's defined by conditions that are persistent 3 weeks or more, because it's expected that most people who get acute COVID infection will have recovered by 3 weeks. But whatever the cutoff point in terms of the duration of symptoms, there is no disagreement with regards to the symptoms. And the symptoms are, I've just put a few of them on here. These are the commonest ones, but we're finding that we're adding more and more and more to them as time goes by. But the common ones are shortness of breath, so breathlessness, headaches, fatigue, cognitive impairment. So by that, I mean brain fog. The sense that people feel that their concentration, their ability to retain information, they're just not as snappy as they were beforehand. But this is not an exhaustive list. It extends to problems with people's hearts, their kidneys, their livers undergoing change. There's a condition called COVID toes, where you have a chilblains type effect affecting the toes. Long COVID appears to be adding to the list of its symptoms as time goes on, and we are gradually learning about this. But these are the main symptoms, and these symptoms of breathlessness, headache, fatigue, and brain fog or cognitive impairment will turn someone from someone who's able to go out to look after their family, to performing their jobs, to someone who is at home depressed, lacking in motivation, lacking in confidence, and being at a loss to understand why after an illness, which didn't require hospitalization, didn't require that they start on any kind of treatment, that they recovered, but they started with these other symptoms that went on and on and on. And this is what long COVID is. And it's estimated that in the UK, there are 60,000 people who have this diagnosis of long COVID. And it is the case that this is going to potentially have a longer effect than COVID itself. And the government has recognized the importance of addressing this problem, because the vaccination program is one thing that's underway and that is doing what it should do. Yes, there are issues, and they are mitigating those issues, as I've mentioned before, around changing the vaccines for different age groups. But long COVID is something that we have not in any way properly got hold of. So the NHS, in wherever you are in the country, they are establishing what we call these long COVID clinics. And you'll see this advertised more and more online and on TV. If you're suffering from long COVID symptoms, and the common symptoms that we used to associate with COVID, the cough, the fever, the headache, you will see more in the way of advertisements on if you're getting breathlessness, brain fog, anxiety and stress. This may mean that you're suffering from long COVID, and the clinics are set up and accessed through your GP, and they use a whole series of approaches. A lot of this is around cognitive behavioral therapy called CBT, of counseling, of physiotherapy, and it's all about getting people back to normal. But for some people, the long COVID symptoms are more than just the effect on their muscular strength and on their breathlessness. It can actually reflect changes in the heart, so the heart can become inflamed and permanently damaged, so that the heart of a 22-year-old becomes more like that of someone in their 80s. The kidneys start to become problematic. They develop something called CKD, which is chronic kidney disease. It's a condition that we often associate with people who have had diabetes for a number of years, but this is now happening in someone who has long COVID symptoms. They may develop problems associated with a rapid cognitive decline. So we know that dementia is more common in people with diabetes, it's more common in people as they get older, but you shouldn't be seeing this kind of dementia-like problem, cognitive impairment, forgetfulness, happening in someone who is in their 40s or their 50s or even younger than that. So there are challenges associated with long COVID that these clinics have even yet to come and to grapple with. So I'm going to lastly move on to the issue and dovetail with Dr. St. John, but in a slightly different way, around COVID and physical inactivity. This is looking towards the future. Now, as we come out of this lockdown situation, everyone's looking forward to next week, where we're now allowed to mix more than we can at the moment, and then in June when we're able to essentially go back to normal. But as a doctor, I see a lot of changes that have happened in people over the last year. And this is not just for patients, this is also with regards to my professional colleagues. And we're all, I don't think there's any one of us, as Dr. St. John said earlier, who has been spared this. I think everyone has been adversely affected by this. And I'm going to look at COVID and the containment of COVID, the lockdown effects, and how that has affected your bodies, our bodies, and how we can help to balance against that, or what we call mitigate that. So I've put on here 4 factors that accelerate muscle loss. And I'm going to define that in the next slide. So muscle loss is a condition that we expect to see generally as people get older. But it can also happen under certain other conditions, such as that as confining someone to their homes, confining them to bed, putting them in a wheelchair. So a whole host of things can do that. So any kind of immobility can cause muscle loss. And I'll explain why I'm talking about muscle loss shortly. So a sedentary lifestyle. Now, how do I define sedentary? Sedentary means still, but a sedentary lifestyle is a situation where out of the 16 hours that you spend awake of the 24 hours of the day, assuming that you do get your proper 8 hours sleep a day, many of us don't, but assuming that you get 8 hours sleep a day, there are only 16 hours left in the day. If you are spending more than 2 hours of those 16 hours sitting down, and you're doing that for more than 2 days of the week, you have a sedentary lifestyle. That's sitting down and watching a Netflix movie, isn't it? So that's why these apps, the apps on these watches are constantly nudging you to actually get up, to walk around and to do things. So a sedentary lifestyle is a form of immobility that will cause and accelerate muscle loss. The second one is an unbalanced diet. If you are not getting enough carbohydrate or protein in your diet, there is not enough to actually form the protein that's needed to actually put the muscle fibers together. Dr. St. John talked about not having too much. You know, we should make sure that we're cutting our portion sizes back and not eating to excess. But having an unbalanced diet, whether you're eating to excess or not, if there's not sufficient protein in that diet and the right levels of nutrients, then that can also accelerate muscle loss. Any kind of inflammation, so damage, if I fall, I hurt myself, then that will cause you not to use the arm or use the leg, and that will cause a breakdown of muscle and a muscle loss. But also inflammation associated with infection. So if I get infected with COVID-19, that's an inflammatory process. That will also cause muscle loss. And not least, severe stress is a problem that is again associated with this muscle loss. So what is muscle loss? I'm going to introduce this term, and I always like to define terms very clearly. There's a condition that we use in medicine called sarcopenia. Sarcopenia. And sarcopenia comes from the Greek, 2 words of the Greek. It means sark, or with the X on it, it means flesh. And penia means lack or loss. So anything that you see with penia in it means loss. So osteopenia, osteo is bone, means loss of bone. Thrombocytopenia means too little platelets. So sarcopenia, flesh, muscle, lack of that is what we call sarcopenia. Now, sarcopenia is typically, if you Google sarcopenia, you'll always see sarcopenia and old age, because old age and sarcopenia go hand in hand, so to speak. Let's just give you an illustration. From your mid-30s, 40s at the latest, you start to lose a small amount of your muscle mass as each year progresses. And it's important to take steps to prevent that from happening, and keeping active, going for walks, has just been mentioned, that actually helps this process. However, that's an age-related loss. And if people are active, they're going out, they're moving around, then they can help to reduce that. When you have a situation of containment, of lockdown, it takes what would normally be an age-related process and it accelerates that even more. So we're starting to see sarcopenia in young people, in young middle-aged people, And I guarantee that everyone will have experienced some loss of muscle mass. The statistics tell us that if you put someone in bed and they are just bedbound, they will lose roughly around 1 to 2% of their muscle mass each day if they're not moving. So sarcopenia is a very, very real issue. And this is this graph shows very clearly the loss of muscle mass that we expect to see, as I mentioned, from someone's early 40s. So here on this axis, this long vertical axis here, we call it the y-axis, this is what we call lean muscle mass. So this is muscle without any fat. And here along this axis, we've got someone's age. So 40 all the way up to 90 years. And you can see how at the age of 40, you've got a good amount of muscle mass. So the average person, 32 kilograms of muscle mass is a good amount to have. But you can see how this muscle mass actually falls over the years. And if you get any kind of acute injury or you become unwell, you're bedbound, you can see how you get little dips in this. But on average, as we get older, we lose this muscle mass. But that's what we expect to see. I'm going to put this in the context of what we call the COVID-19 containment measures in this form of a house. So all governments in the world have said that with COVID-19 infection, person-to-person transmission is by respiratory droplets. So the advice has been that we have lockdown measures, and these are enforceable by law. And I want you to look here at these blue arrows. So lifestyle behavior change, and the mechanisms of muscle mass, body changes, and long-term health risks. So let's look at the top one in terms of lifestyle behavior. So we're spending more time at home because of social distancing, quarantine, self-isolation, and travel restrictions. So there's more time spent sitting on the couch, more time spent sitting at a table, and also there's greater stress and anxiety when your loved ones you can't meet up with them. And what this does is that this actually causes a loss of muscle mass. Because we're not going outside, there's less of an exposure to vitamin D. If you're not moving around, your insulin sensitivity falls. And if your insulin sensitivity falls, your risk of diabetes increases. The synthesis here of muscle protein, the making of muscle protein, also falls. And then over here, this cortisol, oxidative stress, this means that stress hormones in the body increase. And when stress hormones increase, it causes muscle protein to break down. Remember, this is all just down to being housebound. The resultant effect of this is that there are changes in the body's composition. Instead of having nice, good, strong muscle, as you can see here in the pink, you get a loss of muscle mass. But not only that, is that because you're eating more in the way of unwanted calories, unneeded calories, the carbohydrate gets converted to fat and your muscle is replaced with fat. And so we get this condition here, it's called sarcopenic obesity. So there's increased girth around the stomach. You might increase in weight, but you've lost muscle. So you're less lean and it's more fatty. And lastly, the resultant effect of this are these issues here at the bottom in the pink. The long-term health risks as a result of these containment measures. So this is not acute infection with COVID. This is not long COVID. This is what's happened over the last, 3 lockdowns. We've got now increased cardiovascular disease and diabetes that will emerge out of this year of lockdown. We've also got an increase in osteoporosis and fractures because if you're not using the bone, if you're not stressing bone, then it starts to weaken. There's cognitive decline and depression, physical frailty is increased, and quality of life is reduced. And then that, should we get another wave of COVID, increases your risk of being in one of the high risk groups. Now, the good thing is that we can actually do something about this, because you can actually counter the changes associated with sarcopenia. And this is very, very simple. The next few slides will finish off and concentrate on these. Resistance exercise. So using bands to push against the resistance. Believe it or not, within 2 or 3 days, that will start to reverse any changes. Just pushing against the resistance. Household chores, not putting using a brush rather than sending someone else to hoover, or using a hoover. But even hoovering around will help. Getting good quality food. Many people weren't able to go out and eat in other places, so McDonald's takeaway places have hugely benefited during this time. But we should be having more in the way of unprocessed foods, not the processed foods, but the unprocessed foods, and avoid snacking. So, and this just talks about some of the kind of foods that we should be having. So what can we do? Going to a gym is not everyone's cup of tea, and I don't think that's absolutely necessary. But if you have stairs in your home, that's one of the best exercise opportunities, because going upstairs actually puts stress on your muscles, on your bones, and in itself will help to guard against this sarcopenia. Simply moving around, again, will have that effect. If you've got dumbbells, that's great to use those, but it's not necessary to have those. Being out into in the garden, this is why people who are out, who are doing, who run allotments, they're having to lift, they're having to push, they're having to pull. And in so doing, they are unknowingly actually guarding against this potential aspect of sarcopenia. And whatever you do, whether you decide to walk up and down the stairs, do a bit of gardening, start small, start with small areas of improvement that you can actually do, and you don't come away thinking, my goodness, I don't want to do that again, even if it's just 5 minutes. But the World Health Organization, the WHO, said, and this is back in 2016, they said that most adults do not get enough exercise. Many adults are too sedentary. So this was even before we had the scourge of COVID-19. And the recommendation from the World Health Organization is that we should be doing 150, so 150 minutes of aerobic activity. And remember, I didn't say exercise, aerobic activity. So that could be walking up and down stairs, hoovering, gardening, a week. And this is how it would break down. It would be 30 minutes of activity for 5 days of the week, which then gives you 150 minutes, 5 times 30. And then you have 2 days of what they call resistance activity for 30 minutes. And that is the recommended level to guard against this sarcopenia. Okay, so in summary, the last 2 years have been a challenge for us globally. The vaccination program, yes, it has proven effectiveness. Yes, there are risks, there are issues that are still being grappled with, and we're still learning. And we also have a winter coming in about 6 months' time, where there may be new emergent strains necessitating ongoing vaccination programs. So a COVID vaccination program is likely to be part and parcel of our ongoing healthcare for many, many years to come. I've also mentioned the issue of long COVID symptoms. And for all of us, I think that the main challenge will not just be integrating back into society when the rules are hopefully lifted in a month's time, but I think it will be trying to reduce the potential effects that 1 year of containment, necessary containment, those negative effects that has had on our health. But the good thing is that there is something that you can do about that. As long as you're able to move around, as long as you're able to make choices in terms of your eating habits, it's possible for you to actually pull back and to reverse those changes. But the final point that I'll make is that failure to do so will mean that in addition to the 3.3 million people who have died from COVID, I think that indirectly COVID-19 will claim other lives by foreshortening them if we fail to make those changes. And and I'll end by mentioning, it was Timothy, I think it was that mentioned that bodily exercise profiteth little. And I used to hear this as a child and I thought, does that mean that we shouldn't be exercising? And if you look at the interpretation, what it is saying is that he was saying that bodily exercise profiteth little, and that he said he was talking about the importance then of spiritual health. So and the comparison was saying that there is benefit from bodily exercise, but it's more important to obviously concentrate on the spiritual side. So it's not to say don't do exercise because it doesn't give you any benefit. There is benefit there, and it was recognized as far back as in the times of the Gospels. So I will end there, and I will open this up to any questions. I hope you've been able to hear and to understand. Thank you.
Thank you, Dr. Lawrence, for a very thorough and wonderful presentation. Now we've almost come to the end of our session, and this is the time when we ask questions. Now, I have a few questions for you, Dr. Lawrence. One of them is, if there is a fall in deaths, why do we still need to wear the masks?
Yep, very good question. So the deaths are falling, but they have not actually petered out completely. So there is still a significant infection rate amongst the population. Deaths are falling, which is great. But if I go back to my original slide, it will show you that we still have a large number of cases within the population. And as such, it therefore means that it will still be prevalent. And the other side is that not everyone, because it's a free choice, not everyone is forced to take on the vaccination program. Furthermore, it's not just, so even doctors and medical students, if they decided that they do not want to be vaccinated, they cannot legally be forced to do so at the moment. So those people who are not vaccinated, if they were to come into contact with those people who have been vaccinated but are carrying it on their hands or through something that they've touched, then they could potentially be at risk. I think what we're going to see in June is that there will be a further relaxation so that people may not necessarily need to wear masks if they do not feel that they're in a closed environment. But I think there'll be a legacy effect whereby some people will still wear masks almost permanently. And certainly if they're in areas where they are with people with whom they're unfamiliar, they'll probably still wear a mask.
Okay, thank you. So the next question I'd like to ask, what are the red flags of having blood clots following the vaccine?
Okay, that's a very important question. So this is 4 days, usually 4 days after the vaccine. If you start with any dizziness, any headaches, those are the two issues around that. So dizziness, headaches, and sometimes with a fever as well, but it's dizziness and headaches. But this is 96 hours or 4 days after the vaccination, because it's not unusual for people to have headaches, to feel achy, to feel unwell within the first few days of the vaccine. But usually by day 3, those have gone away. We certainly wouldn't expect that to be from day 4 onwards. Now, under those circumstances, it would be a case of, if that happened now over the weekend, it would be out of hours, and they would very quickly fast track that person to the A&E department. They would have blood tests done, they would have an ECG, they would also undergo what's called a CT scan of the head in order to ensure that there aren't any potential clots there. And they'd be started on special anti-clotting agents.
Okay, thank you. Next question is, my son is 28 and got his vaccination a couple of weeks. I am worried that he should.
Sorry.
It's not completed.
Okay.
Sorry, I think you just cut out there. I didn't hear it all.
Yes, it said my son is 28 and had his vaccine a couple of weeks ago. I am worried that it may affect him. I think that was a question that was on.
Okay, so I suppose one would need to know whether this person's son had the Pfizer-BioNTech vaccine or the AstraZeneca vaccine. I'm assuming that he had the AstraZeneca vaccine. If he has had this several weeks ago and he hasn't developed any symptoms, remembering that I said that this starts from 96 hours or 4 days afterwards, usually up to 4 weeks afterwards, then it is unlikely that he will have any problems at all. And the greatest risk or the greatest frequency of seeing this, this clotting problem is after the first rather than the second one. However, the government is now looking at, so if a young person under the age of 30, I'm calling young, has had their first vaccine as the AstraZeneca jab, and they are due their second, because you do need the second one in order to have full protection, they're now looking into the aspect of mixing and matching, as we call it, so that they won't have the second one as the AZ vaccine, AstraZeneca. The second one will be the Pfizer-BioNTech vaccine.
Next question is, what causes the COVID-19 virus to mutate in different formats and strains in different geographical locations?
So I think it wasn't, I heard what causes it to?
What causes the COVID virus to mutate in different formats and strains in different geographical locations?
Yes. So I think you're asking what causes it to spread in different formats or to mutate in different geographical locations. We don't really know why that happens, to be honest. We know that if you have different populations that are together, and you can find this with the cold virus, any kind of virus, that as it moves through that population, it faces different challenges. The conditions are different. There might be more sunlight, there might be less sunlight, but a virus is usually very quick to actually adapt to its circumstances. And if it does so in a way that is very different from the original virus, then it's considered to be a significant mutation. No one knows exactly why that happens, but we see that with the coronavirus. The coronavirus is basically a group of viruses, a family of viruses, which includes the common cold. So if we go back to the common cold, we know that you can be within a group of people, even within your locality, and there might be the cold going around, and then you move somewhere else and you catch a cold, and it's because the cold virus has even mutated to be similar within one area of a population. But that's one of the aspects and one of the challenges of coronavirus, because it can mutate so very quickly. It adapts very, very quickly to its surroundings. And that's why I mentioned earlier on that we are likely to see this COVID-19 being part and parcel of an ongoing vaccination program.
We spoke about long COVID. And one of the questions that was asked, does long COVID include coughing or a persistent or an intermittent cough?
It can. Long COVID can certainly include those symptoms. It certainly includes breathlessness, the cognitive decline, the brain fog, but yes, coughing as well, absolutely, yes. Because we would expect that the coughing from acute COVID infection should have gone away most certainly by 3 weeks. And the NHS puts it further out, and it says that if you are still getting coughing, if you're still getting the lethargy, the fatigue, if you're getting breathlessness, then it may not necessarily be COVID. There could be a whole host of other things, but they are more likely to consider that you have COVID infection, long COVID infection.
Okay, and just following on from that, and how can we distinguish between the long COVID symptoms of anxiety and stress from stress and anxiety as a result of being shut in for so long?
A really good question, and I think that question, I think, is the challenge for these long COVID clinics, because the symptoms that constitute long COVID are so varied and so long and constantly being added to, that you risk actually pulling in people who don't have it at all. They basically have depression or stress down to lockdown, or down to loss, or just down to work stress, other things that aren't at all related to COVID, but they get lumped into the same group. And that's one of the problems that you have when a condition is so, what we call nebulous. It's so vague in terms of what actually defines it. The only real definition that we have is that someone has had COVID infection and that they then develop these symptoms. Now, even about infection, because we don't test everyone, or not everyone might have been tested, I'd put it that way, they may have long COVID, but there's not been a history of a positive test for COVID, because either they haven't presented, or they had such mild symptoms that it didn't even hit the radar. And then they come along with these symptoms that are completely out of the norm for them and are consistent with long COVID. So they can't even use as a definition the fact that you have a positive COVID test, because that would then exclude people unfairly. They have to make this as wide as possible. So yes, I agree. That's a very important question.
Yeah, and that reminds me of, I'm sure we would have heard of someone called Kate Garraway. I think her husband has been afflicted with long COVID for, since March last year. And I understand, although he's now moved back home, he's still, suffering.
Yeah, and in actual fact, Kate, because of her prominence in the news, she highlighted long COVID way before it was fully recognised by us as medical health professionals or the government, because they couldn't understand how this person, once you're out of the danger zone in terms of being in intensive care, one would think that everything would be fine. But he is a real example of someone who was previously a professional, able to do things, and his life is completely changed. And you can see, I talked to you earlier on about sarcopenia. If you look at him, he's not an old man, but he looks like an old man because he's suffered such muscle wasting, such muscle loss. He even had difficulty speaking, and that's the effect of this long COVID or chronic COVID effect. And the other point I should make is that, yes, he was very unwell at the time, but you don't need to have been very unwell. You don't need to have been hospitalized in intensive care in order to develop long COVID. And this is the other reason that I would stress the importance of COVID vaccination, because for those who haven't been vaccinated yet, if they do happen to get COVID infection, the chances of death are relatively low, but there is a significant chance of long COVID infection. As I said, there are 60,000 people so far in the UK, and it's constantly been added to this number, who have been diagnosed with long COVID.
Okay, thank you for that.
Thank you.
Next question is, which of the approved vaccines have greater efficacy and less risk?
Okay, that's a so it depends on how you describe efficacy. The efficacy is basically the, I would say, the chances of your getting COVID infection. So I would say high efficacy means that that's the lowest chance of you getting COVID infection. That's one way of defining efficacy. But another way of defining efficacy could be the risk of someone actually passing it on to someone else. Another way of defining it would be the speed with which you actually get to your protective levels of immunity. So the best way of describing this is to say that there is little to choose from between the AstraZeneca, the Moderna, the Pfizer-BioNTech, the Johnsons. I know we don't have some of those here. They all have a similar efficacy. Now, and then the difference between one that gives you an efficacy of 90% and one that gives you one of 99% is splitting hairs, really, because once you get anything above 70%, you've got very, very good cover. If I roll this back, and I'll come back to this point, if I roll this back by looking at the flu jab, which I mentioned in my last talk previously, that the flu jab, the influenza jab that we have had for many, many years, that at its very, very best, and that's assuming that you have a young person, and by young, a very young person, I'm saying someone who is a teenager, so under the age of 20, then you're likely to get around 60 to 70% efficacy. If you look at someone of my age, you're probably getting in the region of around 30% efficacy. If you look at someone of an elder person, my mum's age, you're possibly looking at best around 15% efficacy for the flu jab. So the flu jab that we use every year is nowhere near as effective in the at-risk population, in the population where if they were to get it, it's really going to affect them. So it's then as a COVID jab. So we know that the Pfizer-BioNTech one, after the first jab, you've got around 70% efficacy. After the second jab, you've got around 90%. With the AstraZeneca, it's slightly different with the AstraZeneca. You have, after the first jab, you have around 50%. After the second jab, you've got around 92%. So they're all very, very similar, but it's important that you have your second injection because the vaccination program is not complete until you have the second one.
Let me just give you an example. Let's give you a scenario. For example, if I'm an 85-year-old woman and I'm saying, no, I don't want to have the injection, what would you say to try and encourage me to have the vaccination?
Okay, so I wouldn't try and persuade anyone for a start. I think they have to make an informed decision. But in terms of presenting that information, I would want to present both the pros and the cons, so the benefits and the risks. The benefits are that this injection is at very, very low risk for them. So the blood clots that we talked about really is not going to affect someone in their 80s at all. We just don't see it in that age group. The risk of an allergic reaction is more so with the Pfizer-BioNTech one than it is with the AstraZeneca one. So if they had the AstraZeneca one, there's hardly any issue there unless they have a history of allergy to any of the contents. It will reduce their risk of dying from COVID-19 infection. It will reduce their risk, even if they don't die, of illness. So many people at the age of 80 will be carrying not one, not two, but 3 or 4 illnesses that they're living with. and those increase the risk of getting worse, significantly worse and fatally worse with infection. So it reduces all of those. If she doesn't have the vaccine, the chances of death if they were to get infected. Now, even if you've got almost the whole of the population vaccinated, there'll be some people who aren't. So that's why we have to wash our hands and social distance at the moment. But it just takes one person to infect that 85-year-old woman, and that could spell the end of her life. So to me, it seems, again, that she would make up her mind on that, but it would seem that for an injection, the discomfort of an injection, bit of pain for a few days, another one a few months, 3 months later, would be enough to give them years with their loved ones, rather than potentially a very quick death, difficulty with the funeral arrangements, because I still think that in the event of someone dying from, even after the lockdown, if they die from coronavirus infection, there might still be some restrictions around the funeral arrangements. Other deaths, I don't think there'll be an issue, but there might still be for coronavirus.
Dr. Steve, what is your take on, in the future, that we may have to be taking a series of vaccinations, maybe against different strains that might mutate from the current coronavirus?
As I mentioned, I think that the coronavirus vaccination program will become part and parcel of our annual UK vaccination. And in actual fact, wherever you happen to live in the world, there will be, I know that coming this year, there's going to be another vaccination program to encompass the strains from India and from Brazil. So this will be constantly fine-tuned. And they've just learned so much. They've had to learn this on the hop whilst they've been going. But the lessons that have been learned by the Joint Vaccination Committee, it's a fantastic rate that they've brought that expertise together. But yes, come the winter of this year, we will be having another vaccination program, because it has to be realized that the vaccination that you and many of us have had, that guarantees your protection for around 6 to 7 months. So we will need to repeat that again and again and again as the years go on.
Next question, Dr. Steve. Reports indicate that a minute number of blood clots was found originally in the under 30s after receiving the AstraZeneca vaccination. Recent scientific reports state that age group has been raised to 40 years, almost 10 years different. And that's this information to raise it was advised by the MHRA. What is your take on that?
Yeah, I don't think that's unreasonable. So, as I said, the stark cutoff point of under 30 is, I can understand why it's been chosen at that stage, because the risk really is very low, very, very low at that stage. And there are risks associated with, I mean, I will give someone, I don't anyway, my nurse will give someone a flu jab, and some people will have a severe anaphylactic reaction from a flu jab. But these are very, very rare, and you're getting into those kind of territories when you're looking at those who are under the age of 30. When you have those people who are over 50, over the age of 40, the risk is very, very low. So the decade between the 30s and the 40s, one could argue that there might be individual risk that is slightly higher, slightly peaked, that would make it not unreasonable for that person to say, well, I don't really want the AstraZeneca jab, I would like to go for the Pfizer-BioNTech. And I think under those circumstances, I think that the healthcare professional would be very understanding around that. I don't think that people will be forced to have the AstraZeneca jab between the ages of 30 and 40.
So there's a risk of that age group going up by another 10 decades from 40 to 50.
Sorry, I didn't catch that, sorry?
So you're saying it's minuscule that age group that was raised from 30 to 40 might somehow raise from 40 to 50.
Yeah, so it won't go from 40 to 50, no, because the risk is just so infinitesimally small that it wouldn't be, that they wouldn't be doing that, no. As it happens, the AstraZeneca vaccine program appears, because we're gradually working through these levels, and AstraZeneca vaccine is not really suitable for the younger age groups, the likelihood is that you're going to see the NHS actually abandoning the use of the AZ vaccine almost altogether, because as you go down through the age groups, you want to be given the Pfizer vaccine, and to have vaccine being produced that's not being used is a waste of resources. So because the vaccination program in the UK at least has moved on at such a pace, that I think that there's going to be less of a call for the AstraZeneca vaccine and more for the Pfizer. The only problem with the Pfizer vaccine is that the storage needs to be below -70, and many GP surgeries, most GP surgeries don't have those facilities to store the vaccine. So you won't be able to go easily down to your GP surgery and have this done. You'd have to go to a special vaccination centre, but that's fine.
Okay. Another question I'd like to ask. This came from one of the participants, and they're asking, my sister is 26, and she's had her first dose of vaccine with blood clots a few days after. Can you advise if a second dose of vaccine will place her on severe risk?
So I'm really sorry to hear that for this woman's sister, but and I hope that she makes a full recovery, because the treatment that is put in place for someone who has these symptoms is very effective, and with recognition, presentation to a medical healthcare team and treatment, these people are usually fine. They recover. But when it comes to the second vaccine, I still would recommend that she has the second vaccine, but they won't be giving the AstraZeneca vaccine. The move will be to give her the Pfizer-BioNTech vaccine, which has no association at all. No other vaccine has shown this kind of association. And the US, they have the Pfizer vaccine, they have the Johnson vaccine, Moderna. They won't use, it's not licensed. The AstraZeneca vaccine is not licensed for use in the US at all.
Another question, Dr. Steve, is if the vaccine is taken outside of the 12 weeks recommended period, is there any risk as if it was taken on the 14th week or the 15th week, or does the efficacy of the first diminish?
So that's really important. So if we go back to the authorization, the license for emergency authorized use of these vaccines was based on the information that the companies produced in good faith, that the first vaccination would occur on day one and the second one would occur around 4 weeks later. The governments, and many governments followed the UK, said that, look, we'll roll out the first vaccination program, get as many people vaccinated as possible. And because there was also data from the companies that it could be given as late as 3 months, they said, okay, well, we can push this as far back as 12 weeks or 3 months. And I'll come on to the question in a second, but what they found was what they call a serendipitous. This was a very fortunate outcome, because they found that having that gap and lengthening it from 4 weeks to 12 months, so 12 weeks, actually gave better protection, slightly improved protection. So it's worked really, really well. Now, beyond 12 weeks, there is no data to support its efficacy. So the concern is that you could lose the protection from the vaccination program if it goes beyond the 12 weeks. So the times that they studied were at 4 weeks and up to 12 weeks, but not beyond and not before.
And in those, if you're taking the first dose, let's say, of AstraZeneca, and you mix the dose to another one, to Pfizer, to Moderna?
Yeah, so yeah, exactly. So that's, you will possibly hear this coming, but that is what is being discussed at this time, to actually allow the mixing of vaccines. So the AstraZeneca first time and the Pfizer BioNTech the second time. The Moderna vaccine has been discussed, and it's been rumored that that might be available in the UK, but I'm not aware that that is actually available to GP practices at all at this time.
Is any questions at all from the floor? Any other questions that wanted to raise their hands to answer question?
Wait a minute, just let's have a look. No, I don't.
No, we don't see any more questions waiting. No. So I think I'll take this opportunity to thank you,
Oh,
Dr. Is there a
is
question?
there someone asking? Sorry, did I see a hand raised? No.
No.
Oh, sorry.
Sister Fair?
Oh, hang on.
No, someone had a question saying, why is the Indian variant rising so fast, I think it said.
Dr. Steve?
Oh, yes, yeah.
Why is the area
Spreading so fast.
So whether this is an Indian variant, I mean, they say that it's different than what we have here in the UK, just as we had with South Africa, we had with Brazil. But the matter of the spread of coronavirus in India is not just down to there being a different strain. What we call confounding variable, the important issue to consider is that when you look at the vaccination program for India, their rate of take-up, they were really, really slow in actually rolling out their vaccination program. In the UK, we have a population of around 70 million. India has a population of 1.3 billion. 1.3 billion. And in the whole of the world, we have 7.5 billion people. So you can see that of the 7.5 billion people in the world, 1.5 billion of them reside in India. And within that infrastructure, rolling out their vaccination program was a slow process. And when we were up to millions in the UK, within just several weeks, they were still bumping along. I didn't put the slide in there because of time, but India was still very, very flat on the lower levels. They're starting to increase, but as a result, India has had an enormity of deaths, and it's almost brought the continent to its heels.
This was a Galaxy 10 S10e asking the question. Sorry, can you unmute yourself, Galaxy S10e?
Hi, Dr. Lawrence. I've had the second dose of my vaccine on Monday. Now, on a daily basis, I have to climb 3 flights of stairs because of work. And this week, I've been finding doing that, I'm really breathless by the time I get to the top of the stairs. And, I don't have to slow down. Do I need to monitor this? Now, the thing is, I have asthma as well. Do I need to monitor this or will it pass? I can hear feedback. Ooh. Ooh.
That's it.
Sorry, did you hear me?
Yes, we
Yeah,
heard you.
yes,
We heard
yes.
you.
Okay.
Thank you, Dr. Steve. Dr. Steve, we can't hear you.
Oh, hang on a minute. Steve? Hang on a minute. Hello? Oops.
Maybe Steve said. He's fixing something.
Hello, can you hear me now? Right, okay. Yeah, so I'll just move this up. What I was saying is that I'm sorry to hear that you've had these symptoms. You say that you have asthma. Now, it's possible that you could be getting an adverse reaction from the vaccine. That's quite possible. But also it could be possible that you're getting a natural, what we call exacerbation of your asthma, which is not related to that. If you do have a fever, if you have anything that is suggestive of COVID infection, so fever, headache, persistent cough, even though you have had the vaccine, it would be important to actually contact, well, at this time of the weekend, it would be the NHS 111 service, because we do realize that some people, it's rare, but some people who have had the vaccine, even though it's 90% effective, can still go on to get infection. But if they do, the likelihood of them getting severe symptoms are much, much lower than if they weren't vaccinated.
That's the final question, Dr. Steve. And let us extend our gratitude to you for availing your time, coming and sharing that expertise knowledge with us. We also would like to thank Dr. St. John in her absence for coming and sharing her expertise with us. And we hope that next year that we can have you back in the open where we can actually put together another health day, but this time in the prescribed place at our church. I apologize for going over the time to all of you that attended. I'm extending my apologies to you for that. And I'm grateful and thankful that all of you have come out and joined us here in this Zoom session on our health on COVID-19. We can close by not giving thanks to those that have assisted in making this possible, starting with the men's life builders and the ladies department ministries. And a special thank you to my wife, Joan, for her very, very sterling efforts in making sure that this happened. And I'd like to also include Jewel, his patience in taking us through some technical issues that we would have been stuck otherwise for that. So I thank everybody. But above all, as usual, I thank the great master, the Almighty God, who has allowed this to happen. Yeah. So I'm
thanking you,
everyone for attending, and we hope that next time that we can have the screen tripled with people. Yeah, but we thank all of you for coming. And without you, this could never happen. So we thank God, yes, and we hope to see you next year. God bless you. But before we pray, as always, we will tell the Father, thank Him for what took place today. We trust that each and every one that was on this Zoom would benefit something from it, and they will take and share what the benefits that they have received through this to others, family and friends. So thank you again. May God bless us, and may God keep us, and may God make His face to shine upon us. May God lift up the lights of His countenance upon us and give us His peace, both now and forevermore. Amen. Shalom, go in peace, and stay safe.
Thank you.
Blessings.
Thank you.